Beauty comes in so many different shapes, forms, and sizes. But what we truly believe is that what is all-encompassing is that beauty is confidence, and that's within everyone's reach. Hello, and thank you for joining us. I am so excited as this is our first episode of GB Davis Plastic Surgery Podcast. I am your host, Dr. Gabrielle B. Davis. I am a board-certified plastic surgeon with a practice in Beverly Hills, and this is my co-host, Jenny Yoon.
Hi, I'm Jenny. I'm a UCLA graduate and currently a pre-PA student. I work with Dr. Davis and accompany her in all of her consultations and procedures. I am equally as nervous and excited for this podcast.
So the goals of this podcast is to discuss everything you would want to know about plastic surgery. So we will talk about popular surgeries to procedures as well as upcoming trends and fads. And when I say everything, I mean everything. So not only will we talk about the indications and the benefits of certain procedures, we will also talk about potential complications and risk.
So if you guys have any questions or if you guys have any topics related to plastic surgery that you want us to discuss, please leave it down in the comments.
So the topic of this episode is everything you would want to know about breast implants. So we know that breast augmentation is one of the most popular plastic surgery procedures worldwide, but it's no secret that breast implants has had a long and complex history in the United States that's still evolving.
Yeah, Dr. Davis, when I was doing my research for this podcast, I actually found a couple of interesting facts about the history of breast augmentation. So the first one is that the first most successful breast augmentation was done back in 1895 when they transplanted a lipoma, which is a fatty cancer from the stomach to the breast. Interesting. Number two is the plethora of materials that people use to breast augment. Like ox cartilage, they use sponges, they use goat's milk, liquid silicone, and thankfully they were all banned shortly afterwards. So I would say I'd have to give them an A+ for creativity, an F for safety.
Oh, well, we know that the modern implants were introduced in the U.S. market in the 1960s. Now, while the older devices were fraught with a host of complications, the newer devices are pretty durable. They have a very low complication profile.
Yes, and I am so glad that we have implants now instead of ox cartilage.
Yes. So Jenny, as a novice or someone that's new entering the field of plastic surgery, what are some of the questions that you had about breast augmentation prior to working with me?
Well, even before starting working with you, I have been interested in breast augmentation, so I did some of my research.
Oh, okay.
And the questions that I had the most is definitely, first of all, the type of implants, as well as like, where is it going to be placed? How is my scar going to look? As well as the potential complications.
Yes, of course.
Yes.
Okay, well, let's get into it.
All right, so I think the first thing that I would like to discuss is the type of implants, especially saline versus silicone. So I actually have saline implants and silicone implants in front of me. This one's silicone, this one is saline. Both of them have silicone outer shell, just the inside material is saline or salt water for one, and liquid cohesive silicone for the other. So Dr. Davis, what would you say are the pros and cons of each?
Okay, so let's start with a saline implant. So one of the advantages of placing a saline implant is that it can be placed through a much smaller incision. The reason why is because we put it in deflated and we actually inflate it in the body. So therefore we don't have to make an incision as big. The second advantage is that if it were to rupture, it's easier to detect a rupture. And the reason why is because the breast will deflate and so it will be smaller than the other side. That is one of the main advantages of a saline implant. However, the biggest disadvantage is that it doesn't have as natural shape and feel as a silicone implant. and it's heavier, as you can see.
Yeah, so it kind of looks like a water balloon in
Yeah.
your breast, which is not ideal. What about silicone implants? I know you prefer, and a lot of plastic surgeons prefer silicone implants. What would be the reasoning behind that?
Yes, because of, as I mentioned before, the more natural shape and feel, and
Mm-hmm.
it's not as heavy as a saline implant. But the biggest disadvantage with the silicone implant is that if it were to rupture, it's harder to detect. So we know that the older generation silicone implants, that when it ruptured, the silicone was everywhere. And so we went in to change those implants out. It was hard to get all the silicone out because it was everywhere. But the newer generation implants, the ones that we use today, the silicone is more cohesive, meaning it is stuck together.
Mm-hmm.
So if it were to rupture, it usually stays within its shell, and that's why it's harder to detect.
So, what can you do to determine whether your implant has ruptured or not?
So, imaging. And so, FDA has certain imaging guidelines for all women that have silicone breast implants. So, their recommendation is to undergo an MRI or an ultrasound 5 to 6 years after the initial placement of the implant, and then subsequently every 2 to 3 years after that to detect a rupture.
Okay, so basically, breast augmentation, you just kind of have to keep up with it just to make sure that it has not ruptured.
Yes, there is some maintenance with it.
Okay, that sounds good. What about the placement of implants? From
Hmm.
what I know, there are three distinct placements that we could use for breast augmentation.
Hmm.
We have the subglandular, which is right underneath the breast tissue,
Correct.
submuscular, which would be underneath the pectoralis muscle, and
Hmm.
then there's the dual plane, which is kind of like half-half
Hmm.
of subglandular and submuscular. I know that you prefer dual plane. Can you explain that in more details?
Yes. So dual plane is like half and half, as you mentioned. So the upper part of the implant is covered by the pectoralis muscle or the chest muscle. The lower part of the implant is in the subglandular location. So what this allows is that there's constriction of the upper pole of the implant and expansion of the lower pole. So it creates a more natural appearing breast, that natural slope of the breast.
Mm.
So that's why I prefer it.
So, can you not achieve that with either subglandular or submuscular approach itself?
It's harder to achieve. Talking about submuscular approach or positioning, it's typically not done in cosmetic breast surgery.
Oh.
It's typically done in reconstructive surgery. The reason why is because there's no breast tissue, so you have
Mm-hmm.
no coverage of the implant. So ideally, if you put it totally underneath the muscle, you have that extra layer of protection. But the disadvantages of that is that the muscle will constrict the implant. Also, the pectoralis muscle is usually not big enough to cover the whole implant. So superiorly, you have the chest muscle or the pectoralis muscle. Inferiorly, you have the rectus abdominal or the
Mm.
abdominal musculature. So it can lead to more constriction in the inferior part of the implant, and then the implant can rise to a more superior location, there creating a high riding implant, which of course is not ideal.
Not ideal, yes. What about subglandular?
Yeah, so subglandular, as you mentioned before, it is underneath the breast tissue but above the muscle. So therefore, you don't have that extra protection and support of the muscle. So I find that when a patient's implant is placed in a subglandular position, that because there's not that support, it will drop faster with time, particularly if it's a heavy implant. So that's one of the reasons why I don't place a subglandular implant. Another reason is that it can be more visible.
Mm.
Particularly a saline implant, if there's any rippling of the implant, sometimes you can see that through the skin when the implant is placed in a subglandular position. So there's one thing that we do as plastic surgeons to test if a patient is a candidate for subglandular placement, and that's called the pinch test. So what we do is we pinch the breast tissue, usually the upper pole, and if you have at least 2 centimeters of tissue or breast tissue within the pinch, then you have enough breast tissue to cover the implant.
Okay. But I am aware that there is a case where you would recommend a subglandular placement of implants, right?
Yes, there is a certain patient population which are female bodybuilders.
Yes.
And the reason why they prefer subglandular placement is because there's no animation deformity.
What is animation deformity?
So animation deformity is when you put a implant in a submuscular or dual plane position, and then you have contraction of the chest muscle. So if you have contraction of the chest muscle, you can actually see the imprint of the implant underneath. So that's not ideal. So if they're out and they're in a competition, they're flexing their pectoralis muscle, they don't want people to know or see the obvious sign that they've had breast augmentation.
Okay, so basically, submuscular or dual plane is fine for most individuals that don't have developed pectoralis muscle, but I guess if you're competing and you have bigger chest muscle, you might be able to see it more obviously.
Correct. Yeah, so it's not ideal.
Okay. Well, in accordance to placement, another thing that interests a lot of people would be the scar or the placement of the scar. So there are 4 different incision types that surgeons can make for breast augmentation. The most popular would be the inframammary, which is underneath the breast, periareolar, which would be around the nipple, and then there's 2 other approaches that not a lot of people use, which could be the transaxillary through the armpit, and then transumbilical, which is through the belly button. So why is transaxillary or transumbilical not favored?
So it's not favored because it's associated with higher risk of complications. So one of those risks is higher risk of capsular contracture, which we'll talk about later, but also it's hard to position exactly where you want it.
Okay, that does make sense. Then between inframammary and periareolar, do you have a preference?
So I don't have a preference. I let the patients decide. Some patients prefer a periareolar approach because they can hide the incision within the pigmented part of the nipple, and that's fine. But one thing I do inform patients is there is slightly a higher risk of capsular contracture with the periareolar approach compared to a IMF or inframammary fold approach. So as long as they are aware of that and they're okay with taking that extra risk, then I will place it with that approach.
Basically, it is up to the patient. They just need to be aware of the consequences, I guess.
Exactly.
Okay.
Exactly.
Oh yeah, Dr. Davis, I have also been seeing this a lot on social media.
Yes.
Like gummy bear implants or teardrop implants. What exactly are they talking about?
Yes, so they are referring to shaped implants. So there's 2 main type of implants. That's round implants, as you have here and what you're used to. And then there's shaped implants that's also called anatomic or gummy bear.
Anatomic.
So it has a teardrop shape where the bottom of the implant is wider than the top of it. And ideally that creates a natural or mimics the natural slope of the breast, creating a more natural appearance in theory.
Okay. Then if that's the case, why are not every plastic surgeons using an anatomic implant?
Well, one, in my opinion, it only makes a difference when it's placed in a subglandular location. If it's dual plane, then you already create that natural slope, as I mentioned before, because you have constriction of the top of the implant with the muscle and then expansion of the bottom of the implant. So I don't think it makes as much of a difference unless placed in a subglandular location.
Oh, so basically round implants, dual plane, and anatomic implants dual plane looks exactly the same because of the top compression.
Yes, in my experience, I can't tell a difference.
Okay. What else?
So another reason why shaped implants are not favored is because you have to dissect a very precise pocket for placement of the implant. If you imagine if you make the pocket too big and the implant were to rotate, then you can have visible distortion or deformity of the breast.
Yeah,
so that's why it's not favored.
Upside down looking breast.
Yeah, it could happen.
Not ideal.
Correct.
And what else?
Also, all shaped implants are textured. And so a lot of plastic surgeons are staying away from textured devices because of a certain risk that's associated with them. And we'll get into that as well.
Okay, so what exactly do you mean by textured?
So texture has to do with the outer surface of the implant. So it can be smooth like this, or it can be coated with a certain substance that gives it textured.
Okay.
Now, the reason why that's important is because a textured implant creates more of an inflammatory process. So, I know what you're thinking. Usually inflammation is like a bad thing, right? Well, if you can imagine, if you get a cut on your arm, your body will create an inflammatory process and then create scar tissue. Well, initially scar tissue can be very tough and it can be very adherent. So it adheres to local structures. So if you place an implant, and you have an inflammatory process and there's scar tissue, in theory, the implant will stick to the chest wall and not move. And that's why it's important to have a textured implant if the implant is shaped.
Yeah, so that sounds like a good thing. What's the problem with it, I guess?
So the problem with textured implants is that it has been associated with a very rare cancer.
Okay, then I think this is our time to kind of segue into complications.
Yeah.
To all the anxious girlies out there, including myself, this would be the core determining factor of whether to do the surgery or not.
Yes.
So short term, I know all surgeries have the risk of complication, which could be bleeding, infection, and malposition, correct?
Yeah, those are the most common short-term complications. Now, with respect to bleeding, most cases of postoperative bleeding will require reoperation. Why? Well, one, if the blood were to sit there around the implant, it increases risk of later infection as well as capsular contracture. So that's why it's best to always go in, wash out the space, and then replace the implant.
Okay, what about infection? Because I know we usually send patients home with some prophylactic antibiotics, and that's good enough to treat the superficial infections, but not the deep infections, correct?
So most superficial infections, and when I say superficial, those involving just the skin, a lot of times they can be treated with antibiotics and they will resolve. But if it's a deeper infection involving the implant, then that does require reoperation. You have to take the patient back to the operating room, wash out the tissue, and the best strategy is to take out the implant, leave the implant out for anywhere from 6 to 12 months, let the tissue settle, and then replace the implant. Now, some surgeons will replace the implant at that time, but keep in mind there's higher risk for reinfection as well as capsular contracture if you do it that way.
Okay. What about malposition?
So malposition just means that the implant has become displaced, so it's not in the correct position. That usually requires reoperation as well, and depending on how it's displaced, there's different surgical techniques that we use to fix it.
Okay, so all of the short-term complications do require a reoperation.
Most of them, absolutely.
All right. And then there's capsular contracture, my absolute nightmare. So, Dr. Davis, what is capsular contracture?
Okay, so let's first talk about what is a capsule. So anytime a foreign body is placed in the body, so a medical device, the body will create a response to wall off that device or wall off that object from the native tissues, and that's called a capsule.
And that is a natural process, right?
So it's a natural process that's found around any medical device that's in place. So if you have a pacemaker, there will be a capsule around it.
Okay.
Now, what's abnormal is if this capsule starts to organize, to thicken, and starts to contract around a breast implant, that can distort the implant, and that's the process of capsular contracture.
Yes, and for capsular contracture, we use something called the Baker's grade to determine the severity of capsular contracture. Baker's grade 1 to 2, that's when you might feel a little hardness in your breast. You might feel a little like tenderness or tenseness of the chest. But when you're looking at the breast, you don't really see any deformity. That's when we usually tell our patients that we're just gonna see if it progresses or not, and if it remains the same, we don't really have to do much about it. But the problem is the Baker's grade 3 and 4. That's when your breast is very hard. You could actually see deformities of the breast. It's quite painful, and that is when we usually have to take them back into the OR.
Yes, so that's exactly correct. That there is 4 different stages. So the less severe stages, Baker's 1 and 2, usually you can watch them. Not all patients will progress to later stages, but those that have stages 3 or 4, those require reoperation to take out the implant, maybe exchange the implant, and then take out the capsule. But just keep in mind that once you have one episode of capsular contracture, you're at risk to have subsequent episodes of it.
And what's scarier is that we don't know exactly what causes it.
That's correct. So we don't know the exact etiology. We know that there are risk factors that put patients at higher risk, one being postoperative bleeding, postoperative infection, the entry approach. Those are all things that we have to take in consideration. But also, in patients that undergo breast reconstruction for breast cancers, those patients that have had radiation exposure for treatment and then have implants placed are at the highest risk of capsular contracture.
Yeah, so I guess the best way to go around capsular contracture is just to try our best to minimize any risk factors
That's
that
correct.
could potentially not cause, but affect the progression of capsular contracture.
You're exactly correct. Minimize the
Yes.
risk.
And then I think you also mentioned that rare cancer associated with textured implants. I think it was the anaplastic large cell lymphoma.
Correct. So it is breast implant associated anaplastic large cell lymphoma. It is a very, very rare T cell lymphoma that has been associated with a certain type of breast implants, and that's textured breast implants. That's one of the reasons why I do not use textured implants in my practice.
Okay. So I understand that it is very, very, very rare, but I'm not afraid that people are still really nervous and worried
Of
about
course.
this cancer.
Of course.
So how does the prognosis look like once people are diagnosed? And what are some ways to identify if you have the anaplastic large cell lymphoma?
Yeah. So one thing is we don't know the exact etiology behind this cancer. We don't know if some women have a genetic predisposition, but women that develop it have a fairly good prognosis. So most of them will require, or all of them will require, removal of the breast implant and the surrounding capsule. Now, depending on the stage, they may also require adjuvant treatment. But with that, they do have a good prognosis. As far as how you detect it, well, one, we know it can happen at any time after breast augmentation. So a new onset of a breast mass is one indication. Second indication is if one of the breasts becomes bigger than the other, it could indicate fluid collection around the implant, which is called a postoperative seroma. And so that is another warning sign of the cancer.
And I think you guys shouldn't be too worried about this cancer as it's associated with textured implants. Exactly the reason why we don't use it and a lot of plastic surgeons don't use it.
That's correct. That's exactly why I don't use it.
Yes. And then, of course, there are a little more controversial complications regarding breast implants, which is the breast implant illness.
Correct. So breast implant illness. So what that is there is a subset of women that after they have silicone breast implant placement, they report a constellation of symptoms, nonspecific symptoms that resemble autoimmune diseases. And that's what we refer to as breast implant illness.
Yeah, and that was the reason behind the moratorium of silicone breast implants.
That's correct. So there was a moratorium of silicone breast implants from the year of 1992 to 2006. So there was a subset of women at that time that were complaining of autoimmune diseases, and they felt that these diseases were related to the placement of their silicone breast implants. So at that time, the FDA took silicone breast implants for cosmetic use off the market to allow more time for research into safety and efficacy. But the conclusion of the moratorium was that there was no clear evidence linking breast implants to autoimmune diseases, and that's when breast implants, our silicone breast implants, were reintroduced into the market for cosmetic use.
Okay, so basically the results were inconclusive.
Yeah, that's the best way to say it. They were inconclusive. Now, in saying that, there's still a lot of active research that's being done on the subject. There's a lot of conflicting evidence in the literature. Some studies have demonstrated that women that have breast implant illness, that if they remove their implants and the capsule around it, that they will have improvement in their symptoms. But there's another conflicting evidence that demonstrate that if the breast implant's removed as well as the capsule, that some will have no change in their symptoms, or some will even continue to have progression of their symptoms. So again, there's a lot we don't know, and there's active studies that are being done.
Yeah, well, I guess, there's nothing we can't really discuss on until we see more results or if there's more research out.
Yeah, we can't make any definitive conclusion at this time.
Well, now I kind of want to divert our attention to frequently asked questions.
Oh, okay.
So, the first question, how often should you exchange your implants?
Well, so breast implant manufacturers will tell you that every 7 to 10 years, you do need to change out your implants because that's the lifespan of the implants. However, most plastic surgeons will advise patients that if you don't have any issues with your implants, there's no need to change them out.
Mm.
Because if you are not having a problem, sometimes having surgery can introduce a problem that you didn't have before.
Okay.
But in saying that, the longer you have a breast implant in place, the higher you are at risk for developing certain complications, one being rupture. So you do have to take that into consideration.
That sounds good.
Mm-hmm.
Next question. What are some factors to consider when choosing an implant size?
Well, there's a lot of things that I consider. I think that the factor that's the most important is patient preference. What does the patient desire? And how I know that is I have patients bring pictures, right?
Oh yeah, we have patients coming in. They say that they want to be a size C. Shows us a picture of a woman with like a size E breast. So it's always important to, I guess, bring pictures and have something to reference to when you're doing the consultation so both you and the surgeon understands what the goal is.
Exactly. You want to be on the same page. So that's the first thing I consider. Second thing is compliance of the breast tissue. So how much can the breast tissue stretch? So you can imagine that a woman that's older, maybe in her late 30s, that has had kids, breastfed, she's going to have more, she can have more stretch to her tissues than someone that's in her early 20s. So that's one thing to take in consideration.
I guess another thing that we measure a lot is the breast width.
That's correct.
Basically, from one side of the breast to another. The breast width has to be approximately the same size as the diameter of your implants. That means that if you have a bigger frame, you could accommodate a bigger implant. But Dr. Davis, what do you do what would someone do if they are smaller in frame but they still want a bigger implant?
So then that's when we would change the profile of the implant.
Profile.
So profile has to do with the AP, or the anterior posterior width or diameter of the implant. So if you have a higher profile implant, you have more projection to the implant. So there's different ranges of projection from low to moderate to high, and different variations in between.
And high profile just means that it comes out more,
Correct.
right?
There's more projection of it.
Okay, that is interesting. So I would say, pivoting from that question, what would you say to a patient that comes to you and asks you the exact implant size would get them to a certain cup?
Well, I would say I don't know exactly.
You don't know. What do you mean?
So one thing I do tell patients is that it will vary. Everyone is different. You know, the things that we mentioned before, breast width, it varies from patient to patient. But also the chest wall. Some people have more concavity to their chest wall, so it's going to project differently. So I know that if they're a 350cc implant on me is going to look much different than a 350cc implant on you.
Yes. So basically, you don't really know until you open them up and see if they have like a divot or if it's caved outwards.
Correct. So I won't know until day of surgery. What I can tell patients is the range of sizes, I think, that we'll place, but I don't know the exact size until surgery. I use in surgery an implant sizer, which is pretty much a deflated implant. I then fill it up with air of up to different sizes, and once it matches the size of the photo that the patient sent to me, then that's when I know exactly what size implant I'm going to place.
And that is why photos are very important.
Yes, exactly.
And then I think another question that people have is pregnancy and breast augmentation. Should I wait until after I'm done having children to get my breast done?
That's actually a really good question. So it's a very personal decision, but one thing I would say to patients that if they undergo breast augmentation in their early 20s and then later in their late 30s they decide to have kids and they decided to breastfeed, there's going to be changes in their breast. So a lot of them will require reoperation after that. What I will tell patients is that if they're looking to have kids in the immediate future, they should wait till after having kids to consider breast augmentation.
Okay, so if you plan to have children in the near future, wait until you're done.
Correct.
If you don't have any like upcoming plans, then it's really up to your discretion.
Correct. Exactly.
This would be the last question of our podcast. Dr. Davis, do you have anything you would like to say to the audience that might be considering breast augmentation?
Yes. So definitely there's a lot of things to consider with, respect to deciding whether to move forward with breast augmentation. And it's a very personal decision. But my goal or my hope is that after they watch this podcast or listen to this podcast, they'll have more information to make an informed decision and make the best decision for them.
All right.
themselves.
Thank you, Dr. Davis.
Okay, so we'll conclude with that then.
Yes. So if you guys had any questions from anything that we talked about today, please leave it in the comments.
Thank you so much for joining us. Bye.